Hi everyone, my name is Cinderella Glava, and I'm currently a PGY1 pharmacy practice resident at the James A. Haley Veterans Hospital. Today I'm going to be talking to you all about transdermal patch administration. The main objectives of this presentation are to describe transdermal drug delivery system, give you guys an overview of the layers of the skin, and talk about the components of a transdermal patch. We will also identify advantages and disadvantages associated with patches, demonstrate how to appropriately administer a transdermal patch, and lastly, review some clinical pearls about transdermal patches. So first of all, to give you an overview of the transdermal delivery system, transdermal drug delivery systems, or TDS, provide a way to deliver medication through the skin into systemic circulation in order to promote healing. They're often used as an alternative to oral drug delivery. TDS is currently separated into 3 generations, and they're listed on the left side for you guys. The first generation TDS often delivers small lipophilic and low-dose drugs into systemic circulation. The most common first generation TDS is a patch. Second generation includes chemical enhancers and iontophoresis, a technique which administers medical compounds into the body through the skin by applying an electric current. The third generation involves microneedles, thermal ablation, or microdermabrasion. For this presentation, we'll mainly focus on first generation TDS and transdermal patches. The diagram on the right provides a visual description of the different components of a patch. So as you can see, these include a backing layer, a drug reservoir, and an adhesive matrix. When the patch is applied, the drug is released and it penetrates through the skin. It is then absorbed into the bloodstream and the molecules are transported to the site of action. Next, I will be reviewing the skin because in order to fully understand transdermal drug delivery systems and percutaneous absorption, you must first learn about the different layers of the skin. A person's skin is his or her largest organ, and it has many functions, including covering and protecting the body, regenerating whenever necessary, and providing limited but essential permeation. The skin has 3 layers. The first layer is called the epidermis. This is the layer that contains the stratum corneum, which is the primary barrier of the skin to the entry of foreign substances, but it's also highly involved in transdermal drug delivery. The epidermis is the layer upon which a transdermal patch is placed upon. It is important to note that if a patient is experiencing an allergic reaction or broken skin, patches should not be administered at the site, as a disruption in the stratum corneum may lead to increased absorption of medication and adverse side effects. We also have to be aware of age-related changes to our skin. Older patients may present with thinner skin, which may increase the rate of diffusion of drug molecules into the patient's system. This can be explained by Fick's law of diffusion, which states that the rate of diffusion is inversely proportional to the thickness of a membrane. Therefore, in this population, we have to be cognizant of a possibly increased drug concentrations. The second layer of the skin is called the dermis. This layer contains connective tissue that gives the skin structure and strength. It also transmits medication from a patch into the deepest layer, which is called the hypodermis. The hypodermis is composed of fat and more connective tissue. This layer contains blood vessels which also reach into the dermis and epidermis. Medication from a patch is transmitted through these blood vessels into the bloodstream. From there, the blood carries medication through the circulatory system to the site of action. I've included some common transdermal patches. As you can see, patches may be used for smoking cessation, pain control, anginal and hypertensive symptoms, depression, and even as a vitamin supplement. Next, we will cover the many advantages and disadvantages of transdermal patches. Patches offer many benefits over traditional oral delivery methods. The first benefit of using patches is the ability to avoid first-pass metabolism and premature metabolism by the liver. This allows for direct delivery of the medication to the bloodstream. Patches also provide controlled release of medication, and this can help avoid increased amount of medication entering the bloodstream at once and causing possible adverse effects. Patches are also beneficial in patients where oral administration may not be feasible. For example, if a patient is experiencing nausea and vomiting. Lastly, some patches can be used for up to a week, which can improve patient compliance. Compliance is also improved by the fact that patients can self-administer these patches. Some disadvantages of transdermal patches include the possibility of skin irritation. As previously mentioned, breaks in the skin may lead to increased absorption of the drug and increased side effects. Therefore, it's always important to counsel your patient to not place patches on irritated skin. Another disadvantage is that patches are limited to certain drugs only, such as low molecular weight and lipophilic drugs. As previously mentioned, the skin is a great barrier and therefore only small compounds will be absorbed. The stratum corneum is also highly lipophilic and therefore there is an increased diffusion of lipophilic medication. Transdermal patches are also limited by the surface area of the patch. Normally the patches are relatively small, allowing for only small doses to be administered. As mentioned previously, controlling the amount of drug delivered to systemic circulation may decrease adverse effects. Because of these very specific requirements, only certain medications are available as patches. Lastly, a disadvantage to using patches is that they may be complicated for some patients to use. This is why counseling each patient on the appropriate ways to administer patches is important. Reviewing administration techniques with patients can help improve efficacy of the medication while avoiding any possible adverse effects. I've also included some review questions for you all, so if you would like, you can go ahead and pause this presentation to go over each question. However, they're fairly easy and just a guide for you guys. The first question is, which skin layer contains the stratum corneum? The answer to this question is the epidermis, which, as we've talked about previously, this layer is very important as it contains the stratum corneum, which is highly involved in transdermal delivery of medications. Next, we will be talking about patch administration. I've tried to make this slide as close as possible to the rubric you will be using during your patient counseling session, but I've mainly focused on the patch administration part itself. So as always, don't forget to introduce yourself and the purpose of the activity to the patient, and also gauge patient knowledge of the product by asking if they've used similar products in the past. I've included this image on the right that looks at different patches and where they can be administered, but always counsel your patient to read the label and make sure they know where they're placing the patch. So the first thing you're going to do when you counsel your patient is, like I said, choose an area of the body that is clean, dry, and hairless, and it's important to let them know that they should not shave an area prior to putting a patch on, because shaving can lead to irritation of the skin, and this irritation, as mentioned previously in the slides, can lead to increased absorption of the drug. It's important that the patient washes their hand with soap and warm water. Remove the patch from the protective pouch without using scissors. Always advise the patient not to cut patches. And remove the protective liner to expose adhesive surface. Apply the adhesive side of the patch to the skin and press firmly with the palm of the hand for 30 minutes. Make sure the patch sticks well to the skin. Counsel the patient that if the patch does fall off, they can replace the patch on the skin if the patch looks clean. If it's been a while or they notice that the patch was missing a fair amount of time later, they can just reapply a new patch to the skin. Advise the patient to wash their hands immediately after placing the patch on their skin. Advise the patient to dispose of used patches appropriately by folding adhesive ends together and keeping out of reach of children and pets. It's important, a proper disposal of each patch is important, as many different patches have different requirements, and a great example of this is the fentanyl patch. For example, the fentanyl patch, it's recommended that the patch be folded in half with the sticky sides together and flushed down the toilet. All other patches can be folded and placed in a safe container and disposed of in trash. Always recommend to your patient to rotate sites when applying a new patch, and advise the patient what to do in the event that the patch falls off, which I've already mentioned. Lastly, counsel the patient on proper storage of patches, which most important is to keep out of reach of children and pets. I also wanted to include some clinical pearls for you all to mention during your patient counseling. If a patient has a tattoo, it's important to advise them to place the patch on a different location as a tattoo may affect absorption of medication. It's important to counsel your patients on the importance of removing transdermal patches before MRIs. Some transdermal patches contain aluminum or other metals in their non-adhesive backing, and they shouldn't be worn during MRIs because they can cause skin burns. Also counsel the patient to not apply heat on areas with patches. Applying heat increases the administration of the medication and it can lead to adverse side effects. Counsel patient to not use on broken or inflamed skin, which we've also talked about during this presentation. And also you can counsel them that it is okay for them to shower or swim without concerns of the patch falling off. But if it does fall off, counsel them that they can place it back on the skin if the patch is clean, or if they've noticed that the patch has fallen off for a few hours, they can just administer a new patch at that time. Next, we'll be going over review question number 2. Which of the following patches should be flushed? As previously mentioned in this presentation, fentanyl patches should be folded in half with the sticky sides together and flushed down the toilet, as all other patches can be folded and placed in a safe container and disposed of in the trash. These are the references I used during this presentation in case any of you wanted to look into more information regarding transdermal patch administration. Thank you all for listening to this presentation, and I hope you have enjoyed and learned a lot of new things. If you have any questions, please feel free to email me at the email address on this slide. Thank you.